Thank you so much for coming today. My name is Darlene Sawicki. I am a nurse practitioner for Mass General Hospital, and a nurse practitioner in the States is a registered nurse that has advanced training, usually a graduate or a doctorate degree in a specialty field. So mine is adult gero, and this is after you've been a nurse for a while, you can go back to school. So in the States, I do have privileges to write prescriptions and care for patients. I do have an urgent clinic that I see neurodegenerative patients as well. But I started my career as a registered nurse in neurology, and I've been there for 15 years now, so I absolutely love it. And thank you so much for joining us today. I'm very excited about this collaboration that we have with the Fawzi Sultan Health Network. So I'm just going to go through here. Our objectives today is basically to describe some of the neurodegenerative diseases, just basic pathophysiology on some of them, some definitions so you know what I'm referring to when I say certain language, and then caring for the patients and the caregivers. So this is really a lecture about approach when you're talking about patients and caring for them and their caregivers. So a caregiver may be a spouse, a child, a parent, or even somebody who's paid to take care of them. So the neurodegenerative diseases that we're going to look at today, as a brief review, I'm sure most of you are familiar with them, is basically Alzheimer's, Huntington's, amyotrophic lateral sclerosis, which is my specialty, multiple sclerosis, and Parkinson's disease. So we'll just do a brief review on any of these. So Alzheimer's disease is the most common cause of dementia worldwide. And we do know it's progressive. It usually hits later on in life. The cause of the illness is still being studied. We're doing a lot of research at this in Mass General on Alzheimer with Dr. Rudy Tanzi. We do know that the diagnosis is predominantly made post-mortem. However, during life, we are able to do a clinical exam. We look at clinical presentation, some neurocognitive exams, et cetera. And basically, the caregiver is telling us how their family member all of a sudden is starting to forget things or maybe not engaging as much as they used to. The risk factors we know are increased age. Female tends to be one. We're not sure exactly why female tends to be a risk factor. It could be that females tend to live longer, and so this just automatically puts them into a greater risk factor. Family history, high blood pressure, stroke, diabetes, anything with a vascular disruption to the system. Early symptom onset is usually subtle memory loss, changes in memory. People say, I forgot how to get home. I used to go to the fitness club every day, and then driving home one day, I just completely forgot how to get home. And they just chalk it up to, I'm getting older, it's no big deal. Actually, it is a big deal, because just because you get older doesn't mean that you're going to lose your memory. So these are little subtle signs that we look for. As the disease progresses, the forgetfulness becomes more and more, and then we do have changes in body and what are called activities of daily living. So bowel and bladder may become an issue, and it's not necessarily incontinence due to any type of bladder changes, but more the patient is unable to feel the sense of urgency needing to use the restroom. Family activities later in the disease, the patient can become non-vocal, non-functional. Sometimes they remain in bed till the end of their life. Medications, basically early onset diagnosis is best, and interventions earlier on. That's the key to trying to help these patients. And there is no known cure at this time. And this just shows you the amyloid plaques. I think I'm doing this right with the pointer. Here we go. The amyloid plaques in the brain cells, and this is what tends to build up. You can see the normal neural fibrils, and this is what it looks like with Alzheimer's. And this is how it's diagnosed post-mortem. So this is my specialty here, so I apologize if it's heavily weighted towards ALS. But this is what I work with every day. So ALS is a progressive neurodegenerative disease. It is a combination of upper motor neuron and lower motor neuron. You must be diagnosed with both in order to have a diagnosis of ALS. The most simplest way I can explain this is upper motor neuron are the motor neurons from the brain to the spinal cord, and lower motor neuron is the spinal cord out to the peripherals. And this is where you see the combination of hyperreflexia and weakness at the same time. You can have increased tone and weakness. So this is diagnosed by a neurologist, and we see a third of our patients present with upper extremity weakness. Third of the patients present with bulbar, so they'll have changes in speech and swallow. They might have some coughing, some slurring of speech towards the end of the day. And then a third of the patients are in lower extremities. Very few, but we do have some that present with respiratory onset. It's usually weakness of the diaphragm first. So they have changes in breathing. There's only 2 FDA-approved drugs for this. One is Riluzole. It's also called Rilotec, and this has been around since 1994. The other one that was just approved in the States last year, it's been in Japan for quite some time as a stroke medication, is Radicava. And this is an infusion that's given almost every 14 days. And so right now we focus our treatment on symptoms and supportive care. There are many options on this for supportive care, and this is the key to good clinical care for our patients. And again, there's no known cure. This, you can see right here, is a healthy motor neuron, and this is to the muscle. This is what a normal muscle would look like. And over here, the motor neuron you can see is starting to atrophy, and then that will then in turn atrophy the muscle. So this is what happens, why you see the muscles wasting away. It's not because they're not using the muscles enough. It literally is the signal is not being able to feed the muscle like it needs to be able to contract like it should. And this is diagnosed through what's called an EMG. And this is done by a neurologist as well. So going on to Huntington's disease, this is a familial disease that we see. We care for a lot of Huntington's as well at Mass General. This one is genetic. So this one is, it's a dominant gene. So if the parents, somebody has a gene for Huntington's, it's dominant, so that means that each child has a 50-50% chance of getting Huntington's disease. It doesn't mean 50% of the children will get it. It means literally each child has 50-50% chance of getting the disease. This is a detrimental disease. This is very sad. It's just like ALS. The onset is typically between 40 and 60 years old. And people say early on that there's some behavioral or mood changes. People seem to be a little bit more moody, not as engaged with the family. And then the term chorea, refers to like the dancing movements that they have in the arms and the legs, and it looks almost like a seizure, but it's called chorea, and it's from the signals from the brain. Depression, anxiety, and some patients do present with some paranoid hallucinations. These are things to watch for as well in this disease. They also can have a flat affect, meaning that they're just not engaged in conversations with you and not really responsive to your suggestions or interventions. And weight loss is a big problem with them. Medications, again, there's no cure, but we are working on this in research, and it's primarily symptom management. If I'm rushing through these too fast, just let me know. I want to get to the good stuff. So this is what the chorea looks like. People have problems with walking and movements, and oftentimes they can't sit in a chair very well, and they'll move around in the chair a lot. So one of the things you have to really watch is risk for fall with these patients. So multiple sclerosis, I understand that there's a large population of patients here in Kuwait that have MS, which is interesting to me, because in all of our literature in the States, it's primarily of a latitude of greater than 38 degrees. And it's the literature that they have recently they are finding that people with MS can be genetically traced back to the Vikings invasion. So they tends to be Northern European. So the clinical presentation is one of the ways we diagnose this, and also through an MRI of the brain and spinal cord. And this is looking the problem with MS is it's a signal problem. So as the myelin sheath, that you think about it, an insulation for a cord, an electrical outlet, if you plug a cord in to run a radio or a television, the signal comes through just fine. But if you cut into that cord and you disturb the electrical lines that are going through, the signal your TV may not turn on or the radio may not turn on. That's MS. So the cord is representing the myelin. And so what happens is that these signals get disrupted. And it can be anywhere along the myelin, affecting different areas of the body. It may be the bladder, it may be vision, it may be walking, dropping things with their hands. And so that it tends to be some of the first signs. The bladder tends to be one of the first signs that we see a lot in the States. Is somebody will say, I had an accident, I'm young, I didn't even know I had to use the toilet, and then all of a sudden I'm in trouble. And so this is something that would give us a suspicion to really do some imaging to understand how what's happening with the patient. There's different types of MS, and this is important to know too, because this is also going to help you care for the patient and help them prepare for what might lie ahead. And the relapsing remitting tends to be the most common one that we see, and this is symptoms come and go. So oftentimes we see onset maybe in the 30s or early 40s, and somebody may say, I didn't make it to the toilet and I had lost control of my bladder, or I had a vision problem, all of a sudden I couldn't see, or I was having trouble with this, and we'll run a scan. And then in a few days they might be just fine, and we not have another symptom for months, even years. This is the most common that we see. The next one is secondary progressive. These come and go, but the symptoms worsen. So every time that you have a symptom, the symptom becomes worse. So this is not as common, but we do see it. Primary progressive, symptoms continue to worsen over time. So the symptoms continue. This one is actually one of the worst ones in the MS. So the symptoms continue to worsen, but then you also have these attacks, these exacerbated attacks. So an acute event will happen. And a lot of times relapsing remitting can go into the progressive relapse. So you may not have a symptom for a long time, and then 5 years later, 10 years later, all of a sudden you have another symptom. Bladder problems, vision problems, walking problems, and now it's starting to worsen. Your walking's getting worse, your bladder control's getting worse, your vision's getting worse. And then on top of that, you may have another issue of an attack, what's called an attack. So if bladder or walking tended to be your only symptom at that moment, you may have another symptom of, let's say if bladder was your symptom, maybe it's vision this time, maybe it's walking. So you're compounding the effects that can happen from MS. And remember, those signals to the TV, that's what's being disrupted. So again, these are things that we look for when we see a patient clinically. They come in and they'll say, I'm having numbness or tingling in my hands. That's a common symptom. And I'm not having any problems with circulation. It tends to be fine. Bowel or bladder. They don't do well in heat. This is another reason why I was interested to hear that there seems to be a high incidence of MS in Kuwait. Heat actually makes them feel worse. So we tend to tell them to stay in places that are cool, stay in air-conditioned environments during the hot months. You want to be in an environment that's really cool. You can put ice packs or cool packs around somebody's neck, ankles, and wrists to help cool them down. We do have medications. It's primarily steroids for the remitting relapsing. That if there's an attack, we know we give high-dose steroids, usually in the hospital, to bring down the attack on the body. And so since we feel this is an autoimmune disease, it is a neurodegenerative disease, but we feel it's autoimmune, so the body's attacking itself, we try to give the body a little bit of a relax and rest with high-dose steroids. We do disease-modifying therapies, and then this is the new drug that I actually worked on this clinical trial. I wish I could say it very well. Aqua Ilysm Ab is the new one. It's an infusion, and this one is for the progressive. This is for the very aggressive MS. This is an infusion, and it works very well. Very little side effects. I believe it's given once a month in our infusion suite. But again, it's just to slow the disease. There's no known cure. And so this is what I was talking about in here. So this is the myelin sheath. The axon is going to deliver the signal down through here. And when it's disrupted, you can see in here where there's a disruption, it cannot send the signal like it's supposed to. So if you break that electrical plug-in, you can't turn your TV on. It's the same thing with the body. Everything needs to work just fine to send signals through. So Parkinson's disease, this tends to be a male, predominantly male. We do have women that have it, but it seems to be higher incidence in men. Again, it's a neurodegenerative disease, and it's the dopamine producing problems that occur in the brain. And I don't know if you can see it very well. The substantia nigra here in the brain, right here, is what helps make the dopamine levels in your body. So when this is disrupted, this is what can cause Parkinson's. And usually we see this as a tremor. We saw a patient yesterday that actually has Parkinson's with no tremor, which was interesting. But usually people report a tremor that they notice. They have like a mask-like face, so there's no expression in their face, which is interesting as well. And it's not too much higher in men, but it is higher in men. And there is such a thing as early onset Parkinson's, but it tends to be typically over the age of 65. So along with the tremor, you also have the shuffle and the hunched over gait. So people tend to shuffle when they walk and they're hunched over. That's a classic sign of Parkinson. What's another interesting thing is that we're doing some research here. We know that Parkinson's, they can have a loss of smell. Dr. Mark Albers at Mass General is actually looking into predictors of smell being a risk factor for neurodegenerative diseases. So the lower your sense of smell is at a younger age, the more likely you are to have a neurodegenerative disease as you get older. It's not 100% yet, he's still working on the research, but we do know that this exists in Parkinson's. So we're looking at it for other neurodegenerative diseases as well. So we know that insomnia, depression, and anxiety is also a big concern in this patient population, and it's predominantly symptom management. So we do have medications that help, like Cinnamon, early on. You want to get the medications into the patient early on, and you also want to make sure that they're compliant with it because it can help them if they're taking it early on. A lot of patients don't like the side effects of these medications. So I always tell patients, what do we know? What do we don't know, right? We know that this medication can help you early on. What do we don't know? We don't know what the side effect's going to be. So let's try this and then see how you do. And then if the side effect is too much, maybe we can ramp up a little bit slower or take our time getting up to the recommended dose. But we want to encourage the patients to help themselves and be safe, and early interventions is key. And again, there's no known cure. So here you can see we have the postures over the masked face, and it really is a masked face. There's no expression in the face. You have stiffness, rigidity. It's called increased tone into the body. And when they walk, they don't move their arms. So when you and I walk, we move our arms to give us balance. They don't. They keep their arms really stiff and still. And the shuffle gait is a big one. So I wanted to give a quick review of pathology. I'm sure most of you knew most of these. I just wanted to give a brief introduction to them. We can go back to them and ask more questions about them, but I want to get to caring for the patient and the caregiver. So this is important because we can see that there's common themes between these two, right? We have all of these neurodegenerative diseases. Gait disturbance, poor balance, risk for fall, right? So we need to make sure that the person's doing okay for fall. Decreased concentration, that can happen with all of these. And it could either be pathological, or it could be that they just had a diagnosis of ALS and they are emotionally distraught and they're thinking about things. It could also be some type of dementia, the tremors, with ALS patients, because of the motor neuron disease. If they get into a certain position, they'll have like a clonus type reaction with their leg or something. So we need to be able to educate them on just move your leg a little bit and that will stop. Fatigue is big in all of these diseases. So this tells us that we need to think about small, breaking up care into small portions throughout the day. Not everything at once. We don't need a marathon in the morning. We need to think about what's most important and what's the safest for the patient and the best optimal care, and breaking up that day accordingly and letting the patient rest in between. Muscle weakness. Sometimes we have what's called, sometimes we have what's called fatigability. And that means when you wake up in the morning, just like all of us, we have energy. Most of us have a lot of energy. And then as the day goes on, we tend to become a little bit more fatigued. And our patients, and with neurodegenerative diseases, they really become fatigued. So most of the energy expenditure should be done in the morning. So as you and I rest for a minute, we catch our breath, we sit down, we have a cup of coffee, we think about the day, we think about what we need to do next. We can replenish ourselves. Most of our patients can't. They'll never get back to that baseline they were at first thing in the morning. So we need to really think about that when we're planning care during the day. All of them are progressive. Every single one of these. And right now we don't have a cure. That doesn't mean we won't. That means right now we don't have a cure. So on the emotional side, this is variable across the board, but almost everyone in our clinic is on an antidepressant in ALS. Almost everyone, not everyone, but almost everyone. Everyone has an emotional situation in our clinic, as well as the MS clinic, as well as the Huntington's clinic. These are devastating, life-changing, family-changing diseases that change the dynamics of an entire family. So we need to really watch out. Some of the depression and anxiety is pathological. It's due to the disease itself. In ALS, we have people that can have frontal temporal dementia, and this can make them disinhibited, and it can make them perseverate on issues. So they're constantly thinking. We had one gentleman that through the entire visit, he would just sit there and rock and ask, am I gonna die, am I gonna die? That's all he would say. So some of it's pathological. Loss of identity, right? These are people that go to work every day or are productive in society, or mothers, grandparents, parents, children, and now all of a sudden they're being told, you have 3 to 5 years, or you have a year, or you have 9 months, or maybe you have 20 years. And all of a sudden now they're a patient with a neurodegenerative disease. They're not Darlene from Boston, so their identity changes. And so it's our role to try to keep them grounded and remember who they are, and to help them keep their identity as long as possible. The flat affect, this typically tends to be due to pathological reasons, not engaged, not wanting to participate in family events or at work, just not really interested in anything. And this can happen as well in these diseases. And then you get into the financial worries to meet the clinical needs. In the States, we have health insurance. Health insurance does not pay for help in the home. So help in the home tends to be private pay. And I think that's how it is here as well. And it tends to be very expensive. So people who cannot afford help in the home, everything is left to the children or the spouse, a sister, a parent, even an ex-spouse. I've seen ex-spouses that have been divorced for 20 years because the patient has nobody to take care of them. The last spouse will bring them into their home and care for them. That means giving up their work or their time or their finances to care for that individual. We know in ALS, it's about $100,000 a year to care for an ALS patient at home. And that includes insurance, help with the medication and insurance. So it can be very expensive. I wanted to point this out because all of you sitting here, so when we think about, I give this lecture a lot, when you're caring for a patient with neurodegenerative diseases, these are all the people it takes to care for them, everybody in here. And this is an entire community that it takes to care for one patient. You have to have a physician for diagnosis. You want to have a multidisciplinary clinic, people that they can go to and really be cared for in their specialties. OT, PT, RT, which is respiratory therapy. RD is registered dietitian. A PCP is an internist. Vendors, for wheelchairs, walkers, breathing machines, BiPAP, CPAP, any of those, social work. All of these people it takes to care for one patient. And this is a progressive patient, so we know that each one of these people at various times are going to have to put in more effort. So we know what sometimes it might be social work needs to put in a little bit more effort versus the physician on that clinic visit because the needs of the patient and the family. I wanted to give an example. So this is our clinic at Mass General. We see 500 patients a year. We only have clinic one day a week. On Tuesdays, I do have an urgent clinic on Wednesdays that they come in and just see me. And this is if they have like a G-tube question. I do end-of-life talks, goals of care, history and physicals for surgeries. But in our clinic, when we see about 35 patients on a Tuesday, it takes 9 neurologists, 6 fellows, a pulmonologist, there's 2 nurse practitioners, 6 registered nurses, 2 physical therapists, 2 speech pathologists, respiratory research coordinators, because everybody wants to learn about research, and then 2 medical assistants, and then we have an MDA representative. And an MDA representative is from the Muscular Dystrophy Association, and they come in and help register our patients in case they need something from the loaner closet. So I just wanted to give you an example of what it takes to care for an ALS patient in a multidisciplinary clinic. So I wanted to tell this story. I have this permission to tell this story. This is a nurse, and that's myself. This patient here was a hospice nurse in the States and was an educator at the nursing schools. And I remember we were at a conference in Florida for ALS, and she came down to be a representative. And we were talking to her, and I remember, she was telling us stories about, when she was teaching and everything. And I wanted to get to know who she was as a patient, and we are taught to remove ourselves a little bit. At this point, we were down at a conference. I could ask her a little bit more freely what's important to her, what are her thoughts, what are her hopes, etc. And I remember she said, Darlene, the one thing I want to do is I want to see a sunset from the beach. That's one of the last things I'd like to do in my life because I don't know when I'll be able to be back on the beach because of the wheelchair. So we rigged up a wheelchair that was able to be on the beach. We rolled her down to the beach and we sat and watched the sunset with her. And I remember on her last weekend of life, she called me to her house and asked me to come over and celebrate her 50th birthday. And I went over and she said, I know I'm not going to survive much longer because her breathing had really escalated. And I remember I walked in and she had a balloon tied to the back of her chair and a glass of champagne. And I remember thinking, oh my goodness, you shouldn't be drinking. You're on these medications. And I thought, and she's a nurse, and she said, this is the last thing I want is my 50th birthday is a glass of champagne and a balloon to celebrate. And she actually passed away 3 days later from that. My point is that it was important for us to find out what this woman wanted in the last few days of her life. We were able to honor that. It had nothing to do with clinical. It's taking somebody down to the beach to watch a sunset with them and hold their hand, knowing that they're going to pass away in a few days, is one of the greatest gifts you can give a human being. And she was a mother. She didn't live to see her granddaughter born. She was very upset over this. Her husband was very supportive. And we also encouraged him to participate with us in honoring who she was, and what was important to her. So basically, you really need to know about their story, who they are. It means something completely different to her to be diagnosed with ALS, somebody who dealt with death a lot, a hospice nurse, versus somebody who might be in their 20s, who hasn't had children yet, who hasn't married yet, versus somebody who's a business person that's in their 60s, owns their own business, and is trying to now think of legacy as if they pass away from ALS. So you really want to get to know who the person is, what's important to them, how do they want to live their remaining days with us, and we need to be respectful and honor that. And it's okay to ask their story, what's important to them. You can say what's important to you, what's important to your family, what's important to the people around you. And I also tend to ask a lot, what are you afraid of? Because sometimes patients are afraid of things that are not real. They read something on the internet and they say, oh, I read this, I don't want to die this way. And sometimes, you know, I'm like, it's physically impossible to die that way. So let's lay it on the table. Let's talk about what you're afraid of. And that gives you an opportunity to find out who they are. And this is not something that happens the first day you meet them. This is something that is built on trust, respect, and when the patient knows about the dignity that you are providing for them. And I have to tell you one last other story, and then we'll go on to the next slide. I had a nurse that had ALS, and she was tough. Oh, she was tough. The physicians were scared of her. They wouldn't go into the office to see her. I'd have to go in and talk to her. She was always very mean and nasty. And I remember telling one of the fellows, you can't be afraid of her. You have to go in there and engage with her, because this is a test. She's going to test you to see, can you put up with the hard times just as much as you can the good times. So I remember there was a fire drill, or not a fire drill, the fire alarm went off in our building, and the physician was going to do a lumbar puncture. They were going to get cerebral spinal fluid from this patient. And the patient heard the fire drill, and the physician said, oh, we'll put you in a wheelchair and we'll escort you outside. And she said, I'm not going anywhere. You're going to finish this lumbar puncture. And the physician came out to get me and said, she won't get in the wheelchair. And I said, she's getting in the wheelchair. So I went back in and I said, you know, you need to get in the wheelchair. We don't know if this is a real fire. We're doing this. I got her in the wheelchair and she complained the entire time and, you know, was real nasty to us and everything. And I finally said, your safety's number one. Everything else we can talk about later, but your safety's number one. And then after that, she started to calm down a little bit. After that, when she would come in, she would ask to talk to me and see me. She was a little bit nicer to the physicians. She was a little bit nicer to the research coordinators. Then she started to open up who she was. She was so angry that her life, just as she just retired, she worked her entire life. She and her husband were very well off, and she had worked so hard her entire life. A month after she retired, she's diagnosed with a terminal disease. That was very fast. She was bitter about this. We became very close, and about a year later, I remember I was in clinic, and one of the nurses came and got me and said, Darlene, Mrs. Jones is in the waiting room, and she's been sitting there for you for 3 hours. And I said, oh my goodness, I can't believe this. She's going to be so upset. She said, she's not on my schedule. I didn't have her on my schedule. I can't believe this. I went out there and she was with her husband. She was smiling, and I said, oh, you know, Mrs. Jones, you know, what can I do for you? I said, I'm so sorry you've been sitting here. And she said, Darlene, it's fine. I didn't want to interrupt you caring for anybody else. I just wanted to come and say thank you so much for all of this time, and thank you for never giving up on me or never wavering. And she said she wasn't doing well. And essentially she came in to say goodbye. She sat there for 3 hours. This woman has very little time on this planet left. And she sat there for 3 hours to say goodbye to me. I mean, that is the biggest compliment I've ever been given in my entire life. What an honor that was. And it's because we didn't give up on her. It was a test. So just remember that. And she did. She passed away probably about 3 weeks later. So it is okay to laugh. It's okay to cry. It's okay to be with your patient. It's okay to hold their hand. It's okay to ask them how's today? You don't have to say, how are you doing? You can say, how is today? Is today a good day? Is today a bad day? Is today an okay day? It's okay to ask those questions, because that helps you tailor your care to them too. So these are some of the issues that we face as clinicians of people with neurodegenerative diseases. False confidence. This happens all the time. I do this at home. I don't need you to help me do this here. I don't need you to help me walk when we're in the mall or we're at the doctor's office. I do this, I walk by myself all the time at home. And so I remind them, when you're at home, you have muscle memory. You know where your coffee table is. You know where your couch is. You know where your bed is. Your bed's been the same height for the last 15, 20 years. When you're someplace new, you have no muscle memory. You don't know there's a rug or there's a lip right here. You don't know there's a cord over there. So this is my job, is to keep you safe in new environments. So that false confidence, that's where a lot of accidents happen, falls happen. You know, we just had a patient 2 weeks ago walking on the trail, and her caregiver had the dog with her. The dog got in front of the patient, and because she has ALS, she has no upper extremity, she fell forward and broke her mandible, and she has her jaw wired shut. She almost died, but she couldn't protect her face from the fall. It was false confidence. She walks around at home. She insisted she wanted to go walking in the park. So things like this happen. You want to do modified exams. If you see that somebody doesn't have use of their upper extremities and they're walking around like this, and you need to take a blood pressure, you need to stop and think, if I go to grab your arm, that arm may sublux. It might come out of the socket a little bit because there's no muscle mass to hold it into there. So when you're going to approach someone, you always want to tell them, is it okay if I take your right arm or your left arm? You always want to tell somebody you're going to touch them to take a blood pressure. And they'll tell you, you can't move my arm out, you can't lift it up, or take it on this side because it's too much pain. I have frozen shoulder. Or it hurts too bad. And then if they notice that you can't move it at all, you definitely want to get a physician, physical therapy, and physiotherapy in there to see if it's been dislocated or subluxed. Loss of control and fear, we talked about this, that the fear can be really great. The unknown. As clinicians, we can't tell a patient, oh, you have 2 years, 3 days, 4 hours, and 36 minutes to live. We can't even tell them like how fast this is until we've been able to trend it over time. So this is a really hard concept for patients to understand. Their entire life, if they had a sinus infection, they know they're going to be okay in usually about 10 days. If they had, a cut on their arm, about 3 days, it should heal up, maybe a little scratch after that. So they've had anticipatory results in their health care. This is neurodegenerative diseases is not on a scheduled time. It can fluctuate. So that trust, we talked about that. Caregiver burnout. I give a lot of talks on this. It's called, in the States we have what's called compassion fatigue. And this started with nursing. A nurse coined this phrase in the emergency room. She noticed that the nurses in the emergency room were just not as giving and being present for the patients as they were earlier. And she started to study this, and she found out that what it was is they're just burnt out. Constantly the sadness, constantly the same thing, people dying in front of them. And you can have what's called compassion fatigue. You just can't give any more compassion. We see this in nursing a lot. We also see this in the caregivers at home, the family members, the spouses, the children, the grandparents. You can see it in their eyes. And in the States, we take a picture of the president before they go into office, and then 4 years later, and they've aged about 20 years in 4 years. It's the same thing with the caregivers in the home, the spouses, the children, the parents. You can see the age, and that can come from compassion fatigue. So we need to think about that as well. Nursing burnout is in line with that. So nursing-focused care in neurodegenerative disease, multidisciplinary approach is the best. We know this, there's been published data on this. The AAN, the American Academy of Neurology, actually recommends a multidisciplinary approach. The Institute of Medicine, in their 2012 report, reported that they wanted nurses at the table with the physicians in the multidisciplinary approach as well. Patients do better when people know them. And who is spending most of the time with a patient, right? It's the nurses are spending most of the time with the patient. We actually have it set up in our clinic where the nurses are primary nurse for a physician. So a lot of you met Dr. Merit Sokovich or saw her talk yesterday. each of the physicians have a primary nurse. So their patients know they can call one nurse, that's their contact, they can get a hold of that nurse. If they need immediate help, they can come in and see me. If they want to schedule an appointment with the doctor for later on, they can schedule an appointment with the doctor. And then I do a leapfrog, so I see the patient every other visit. So the doctor does the diagnosis. I'm not a neurologist. They do the diagnosis of ALS. I see them in about 2 weeks after that to find out how they're doing with that diagnosis. Do they understand the medications? Do they understand what the doctor said? And we review it. And then 3 months later, the physician sees them, and then 3 months later I see them, and in between there they have a registered nurse that they can call and ask any question to. And that nurse knows that patient. So we know team approach. They need to have access to tests and exams. Like we do the ALS functional rating scale every visit, which is huge. So that tells us, that can give us a lot of information for patients if they want to know if they're a fast progressor, slow progressor. You know, this helps us trend patterns over time, symptoms over time. Outside resources, help in the home and community. It's important that you engage the community and the home. It takes an entire village to care for one patient. So it's important to know your resources, who they are, what they can do for the patient, and to keep your patients made aware of where these resources are. That's another thing that's important to them. And modifications for the home. You're always thinking, rugs are my enemy. I go into a house that has rugs and a neurodegenerative patient, and I can't tell you, about 13% of ALS patients die from falls, from head trauma, because they can't protect themselves, and rugs are notorious for that. You want to make relationships with vendors in your community. So that way if there's a problem with the BiPAP or the CPAP, you can call somebody up very quickly and say, I need a favor. I need you to come out to this patient's house today, fix this machine today. You want to have those contacts. And then symptom management, you always want to check that they understand what the physician said. So when they get a diagnosis of ALS, they've just been told that they have a terminal disease. If they get a diagnosis of Huntington's disease, you know, if they have a diagnosis of Parkinson's or Alzheimer's, you want to make sure that they understood what was said. And you don't have to insult somebody by saying, did you understand what the doctor said? But you can say afterwards, do you have any questions? This is a lot to hear today. Do you have any questions for me? Is there something that I can expand upon? Do you have any questions about the medication that you were prescribed? Do you have any worries? And they may not write that in there because they're processing the information that they were just given. So it may be a few days before they come back to find out if they have more questions. A good idea is follow up in the clinic, is maybe after a diagnosis, is to reach out to the patient to find out how they're doing on the phone. Sometimes they didn't hear it, they heard a diagnosis and that was the end of everything they heard. So you want to be able to evaluate also what are called adverse effects from medications, GI upset, any problems with other medications. They seem their behavior acutely changed. Nobody's behavior should acutely change in any of these diseases. You don't wake up one day and then have an acute issue of behavioral change. You also don't wake up one day and all of a sudden just can't walk with these things. These are progressive diseases that come over time. You want to offer non-pharmacological interventions. Rest is a huge intervention. Be good to yourself. I tell people, when you have a neurodegenerative disease, you have $1 or 1 dinar worth of energy. You need to spend that very wisely. Only do the things that are important to you and the things you want to do that day. You don't have to see people you don't want to see. You don't have to read books you don't want to read. You don't have to do the things you don't want to do. You need to reframe your thinking and be with the people that mean the most to you. Spend that dollar of energy very, very wisely. And you also want to make sure how the caregivers are doing. This is hard to see, but this is what I teach the nurses. If you advocate, educate, and you participate and collaborate, you're going to alleviate. And it's so true. You need to really educate people around you. You need to advocate for your patient. When a patient goes to an emergency room at another hospital, they have the physician there page me, I get on the phone, I talk to the physician, I explain that like in ALS, they can't breathe, you don't slap oxygen on them without a BiPAP machine. They can't burn off the CO2. So you really need to educate and collaborate with different people. What does it mean to be a nurse for neurodegenerative disease? So this is the work that was done by Jackie Somerville, who's a nurse PhD. She's also the chief nursing at Brigham Hospital in Boston. And it's called Health is the Expanded Consciousness. So I tell patients, my role is to bring you to health. My role is not to cure you, but it's to bring you to health completely, right? So my role is to find out what your fears are, what your hopes are, what your worries are. How can we help you move along this disease, being present and being healthy? And how do I help you as best as I can, culturally, emotionally, clinically? And so my role is to care for the entire patient, not just for making sure that they don't fall. My role is to make sure I care for the entire patient, and also the caregiver. Sometimes caregivers need to be pulled aside. You can see it in their eyes, and I'll say, how is today? And I did this last week, and one of the caregivers said, I'm starting to resent, and that makes me feel bad. And then it's a simple statement. You're a human being, you get tired. It's okay to be resentful today. Tomorrow you're gonna dust your kneecaps off and you're gonna be just fine. And let's see how we can do this. So we give some interventions for the caregiver, respite care. How do we get them out of the house? How do we get them away to just breathe for a moment? Most of the caregivers will not leave for more than a day or so because they just are too afraid that nobody understands how to care for their loved one except for them. So we really want to work within those dynamics. So really knowing your patient. And these are individual people. There are no two patients alike, none. Everybody has their own story. Everybody comes with their own baggage. Everybody comes with their own hopes and dreams and worries. And so it's our job to find out what those are. So then we can also suffer from compassion fatigue. And so we need to take care of us. How do we care for ourselves? One of the things is, everybody says, oh, Darlene, did you see that movie about the ALS patient? I didn't. One of the things I do is I don't watch those movies. I do this work every day, 70 hours a week. I don't need to go home into my home with my husband and watch a movie about this. I know what the ending's like on this movie. So I take care of myself that way. I also know that when I go into the respiratory ICU floor and I'm helping manage a patient that cannot breathe and has passed away, I'm not going to go to the budget meeting that I have right after that. I'm going to give myself a moment to collect my thoughts and be mindful that we just lost a patient. A human left this planet to a neurodegenerative disease. So I'm really good to myself with this as well. I learned that the hard way. And these are things that we need, the know thyself routine. It is important. Rest when you need to rest, breathe when you need to breathe. And then remember that just because somebody is lashing out in anger, you're not to be abused, but just remember that this is probably fear and anxiety. It has nothing to do with you as a human being. So trying to keep yourself in perspective. And you also have a story. So a lot of times I tell the nurses journal, or we have a nursing committee that we sit and we can talk to each other safely. Can you believe this happened? Or this happened. Or sometimes the nurses can come into my office and they'll cry because they have bonded with this patient for so many years, and then the patient passed away. And I tell them this is a safe space. You can absolutely cry. And it's okay to cry in front of the family. It shows that you cared about that person. It shows that that person meant something to you. So this is also, you have a story to tell. You come with your own baggage, your own fears, your own worries. So it is okay to be an individual as well. So we do have some interesting things that are coming in the future. At Mass General, we just started a neuro brain health initiative, which is we're looking at basically 3 buckets, as Dr. Rudy Tanzi put it. One is for red, people who have already been diagnosed with certain diseases that we will care for them. Yellow is, it's a genetic form that maybe we need to be screening these people and monitoring them, over time to see if they actually develop the disease, and then green, people who might be risk factors, high risk factors. Family history of cardiovascular disease, family history of stroke or anything like that. They used to smoke, 30 years ago. So these are the people that we're looking to care for. If we can catch it early enough, maybe we can prevent it. So this is what we are opening up at Mass General. When I first started with Merit 15 years ago, we had one clinical trial. I think we have 30, and I can't tell you how many biomarker trials now. We just keep going and going. Merit and I always joke that we cannot wait to be in the unemployment line when we cure this disease, and she's promised that she's not going to retire until it's cured. And then the multidisciplinary approach. This is, I can't tell you, the biggest key. It's going to save you. It's going to be better care for the patient. It prevents burnout from the nurses, the doctors, PT, RT, OT, SLP, everybody. Everybody needs to be an expert in what they do. Here's my contact information. I really welcome if you have any questions. You can email me, you can ask me a question. If you want to share your story, you can share your story with me. And I'll open it up for questions now. And I really appreciate your time and energy and waiting for me patiently. I apologize for the traffic. Thank you. Any questions? Any questions about the pathology? Yes.
A person who looks very normal, their activities are very normal, but only problem that person is having a dropping, like she or he will drop books or things. So is she diagnosed with MS?
They're just dropping things. So. You were asking if their only symptom is dropping something, you're wondering if that person has MS. They would need a formal workup on that. They would need to see a physician, a neurologist, and this would be done through a clinical examination, clinical presentation, and the MRI is the big thing. Sometimes they'll do a lumbar puncture just to rule out any other type of issues as well. So they should have an appointment with a physician soon. Any other questions? You can ask me anything except my weight. No? Thank you so much. I hope this was informative for you. And I commend all of you for being here, because this means that you are vested and interested in caring for people with neurodegenerative diseases. And I'll be around, so if you have any questions. Thank you.